Tell them that.
Hey, everybody, we'll get started in just a couple of minutes, so just hang out. Alrighty, thank you everybody for attending our ventilator nursing care lecture. I just wanted to, I'm Brooke, if you don't know me, I know a lot of you know who I am, but I'm the CES in Boise, and I just wanted to introduce Emily, who is going to be giving this presentation for us. Emily is one of the clinical education managers for our department, and in particular, why she is the absolute expert to present this topic to you is she is a ventilating queen. And so we really have the best person here to be teaching us about this. So I will pass it off to Emily to get going. We are going to record this, and so if anybody has to like jump off partway through, anything like that, just shoot me a message and I'll make sure that you have access to the recording to watch later.
Thanks, Brooke. As Brooke said, my name's Emily. I know a lot of you know me, but I also know we've got a handful of different teams here. So yeah, we're here talking about ventilator nursing care today. I am super excited to be chatting with you. This is one of my favorite subjects ever. Prior to joining MedVet, it's something that my career was largely focused on. So I'm very excited to have you all join. So today, our scope is going to be somewhat narrow. This is a huge subject. So we're not even really going to be scratching the surface here. We could very easily be here for days talking about everything that goes into ventilating a patient. So I'm really just going to be focusing on outlining your role as a technician in the ways that are unique to ventilator patients. So in order to keep this talk within a reasonable time frame, I am going to assume that you're already somewhat familiar with critical patient monitoring or anesthesia monitoring, very similar. If you aren't, this is still going to be able to provide a good foundation for you, but I'd encourage you to chat with your CES about some resources out there for more general critical patient monitoring, because we're not going to go into those generalities today unless they are related to ventilator patients. So my hope is that you're not going to walk away having memorized everything I said. This is just an introduction, and as I said, it's a huge subject. So for some of you, this may be your first time learning about this. For others, you're going to have had exposure to everything I'm going to be talking about today. So what I really want is that this is going to spark thought and conversation, and then I will provide these slides as a resource for you after this presentation as well. If you have any questions, we will have some time at the end, but you're also welcome to drop them in the chat so you don't forget about them. I am very happy to answer questions in the moment as well. So if you want to grab my attention on a particular slide, you are welcome to unmute. Otherwise, we can get to those questions at the end. So I am going to start with a very brief introduction. I know a couple of teams here are using the Servo-U ventilator, including you guys at Boise. I did do a much bigger talk on the ventilator functionality and how to set it up. So this is just going to be generalities. Starting with why is mechanical ventilation so special? Well, contrary to the anesthetic ventilator, and just like high flow, if you're familiar with high flow oxygen therapy, we can adjust the oxygen level and provide humidified air with a ventilator. That's different than an anesthetic machine. We also, with the ventilator specifically, get to set a lot of parameters to control the type of breath a patient receives and get information on the patient's pulmonary dynamics. So this is definitely a big step up from high flow and is typically, now that high flow is available, going to be reserved for kind of the most critical of the critical. So starting with some background, this is a fairly tough but important slide. I wanted to talk about this study from Kate Hopper, who's kind of one of the preeminent researchers for veterinary ventilation. And she did a study in 2022 that looked at survival rates for mechanically ventilated patients, and it's really only around 22%. So compared to human medicine, they tend to get numbers that are about 50% survival for ARDS and up to 70% for non-pulmonary cases. So 22% might seem pretty low on the surface there, but outcomes do depend heavily on disease process, which is not captured in that 22%. So we get better outcomes with patients who are hypoventilating due to CNS disease, for example, better outcomes for intoxications and some neuro cases. And we definitely see worse outcomes for ARDS, intracranial disease, and post-cardiopulmonary arrest patients. What's really interesting is this study is a follow-up to one that Kate did in 2001. And what they found was that despite advances in medicine, like significant advances in medicine, outcomes haven't improved in veterinary medicine. They've improved in the human world, but not in vet med. So this is where my perspective kind of comes in here. And my thought on that is that a big piece of that is experience. Ventilation is really complex. It's a hands-on skill, and most veterinary teams don't do it often enough to feel truly comfortable with it. So when these cases come in, they're really high stakes and they're really unfamiliar. And that's going to be the predominant driver of outcomes, in my opinion, in veterinary medicine. Whereas in human medicine, they have dedicated teams and respiratory therapists that are much more familiar with all that is involved in ventilation, right? But that doesn't mean we can't do it well. It just means we need to be intentional about understanding what these cases require and to be really prepared. So I kind of want to bring you along with me here because I'll be honest, 22% doesn't sound great, but I do want to reframe that a little bit. Like, how often do we take those odds in other cases? 22% might be the survival rate of a hemoabdomen, right? Long-term survival rate anyway. Like, we take those chances a lot on those really septic patients, for example. So 22% really isn't that bad when we're doing something this difficult and combating some of the toughest diseases we have to treat. So I do want to spend a little bit of time trying to convince you to believe in this therapy as much as I do, because I am also a firm believer that if you don't think that you're going to save a life, that's going to impact how you treat that patient. So I want us to approach all of these cases as if they're treatable and survivable, just like we would with CPR, right? So as Brooke alluded to, prior to joining MedVet in this role, I worked in a practice where we ventilated 3 to 4 cases a month, like all the time. It wasn't uncommon for me to literally move into the clinic to manage these cases. And as a result, our outcomes were much closer to human medicine, where we had somewhere around a 50 to 60% survival rate. I don't believe that's because we were better. We didn't have like a uniquely skilled team, right? We weren't superheroes, but it's the repetition and the familiarity with these cases that led to those success rates. We were more comfortable, we recognized problems faster, and we adjusted for those problems a lot earlier. So I want you to think about any difficult skill that you've learned, even if it's just placing an IV catheter for the first time, and think about what your outcomes were when you first started. Like, they probably weren't great. This is going to be the same thing. Ventilation is a learned skill. And the reality is not every hospital is going to see the volume that I saw. And in veterinary medicine, we also deal with things like delayed intervention due to finances, where we might try oxygen therapy or high flow, even if we know that case is going to head towards the ventilator, or we're pretty sure it is. We're going to try those other things first, which is going to delay ventilation and worsen outcomes. That's unavoidable, right? Like that's the reality we face. So the goal here isn't going to be volume. It's not going to be repetition. It's going to be preparedness. So that's what I want all of us to approach these cases with. That if we can familiarize ourselves and refamiliarize ourselves, if we haven't seen a case in a while with what we're looking at, we're going to be able to recognize changes early and have a plan of attack for these guys. This is Cosmo. You're going to see a lot of pictures of him in this presentation. He's one of my favorites. He was on the ventilator for about 2 weeks, and you just kind of fall in love with these patients when you're nursing them so closely for that long. And then when they wake up, it's so great to meet their personality. But he went home. He was just a puppy. I think he was 8 months old when we ventilated him. So I still get a Christmas card from his family every year, and it's been almost 8 years later. So these are definitely the cases that make all of that work worth it. So bear that in mind. They do come off the ventilator, and we can have just an amazing relationship with that pet and that family afterwards. So we're not going to spend a lot of time on respiratory therapy or theory here, but I do want to briefly talk about indications for ventilation because I do think it's really important for the technician to understand these, because we are going to be monitoring these patients when they're on oxygen therapy or on high flow, and we should understand what we're looking for when we need to start advocating that those therapies are not enough and we might have to look at ventilation. So this is going to be fairly brief, but we are going to talk about it. The first is fairly obvious: severe hypoxemia or low blood oxygen levels. This is one of the most common reasons we escalate to mechanical ventilation. So obviously, if a patient can't maintain adequate oxygenation despite supplemental oxygen, they need more support than we can provide non-invasively. This is often going to be due to significant lung disease, so things like pneumonia, pulmonary edema, or ARDS type conditions. But at this point, we're not just giving oxygen, we're trying to improve gas exchange, and that's where the ventilator comes in handy here. And we also have severe hypoventilation. This is different than low oxygen levels. This is essentially a ventilation problem, not an oxygen problem. Patients are not moving enough air, so CO2 builds up in the body. Common causes of this could include neurologic issues, sedation, think anesthesia. It's a big reason why we use anesthetic ventilators. Respiratory fatigue, so they've been breathing so hard for so long that their respiratory muscles become weak. But we can also see severe respiratory muscle weakness as a result of other conditions as well. So these patients need a ventilator to actually breathe for them. No amount of oxygen that we put these patients in, even if we were to put them in hyperbaric oxygen, is going to correct their condition. They actually need that ventilator to breathe. We might also put patients on a ventilator for increased ventilatory demands. Now, this is less common in veterinary medicine, more common in the human world for sure. But sometimes patients can technically breathe, but they can't keep up with what their body needs. So this is an increased oxygen demand from the body itself. This can happen in conditions like sepsis or severe metabolic acidosis or high demand oxygen states. So what you'll see in these patients is an increased work of breathing that can lead to fatigue. And eventually they will crash if we don't intervene. So ventilation here is about reducing the work that it takes for them to breathe. So they can use that oxygen for other things like combating sepsis. And then failure to respond to high flow oxygen therapy, or oxygen therapy generally if you don't have high flow, but I do believe all the teams joining us do have high flow. So high flow is typically going to be our last non-invasive step before we jump to ventilation. If the patient is still hypoxic or showing severe increased work of breathing despite high flow, that's a clear signal that we need to escalate to the ventilator. And we typically wait about 30 minutes after initiating high flow oxygen therapy to make that decision. We don't want these guys to have like a protracted period of really increased work of breathing on high flow, just fingers crossed, hoping that they're going to get better. Now, again, that's very ivory tower thinking. Oftentimes, it's going to be a long conversation before we put a patient on a ventilator, and the conversation itself is probably going to last longer than 30 minutes. But if we are practicing gold standard and in a world where finances don't matter, right? Not our world, but pretending that there's a world out there, we would jump to ventilation after 30 minutes of high flow oxygen therapy and the patient's still failing. This is one of those places where early recognition from the technician can really matter, because we can go to that clinician and say, hey, this patient's work of breathing didn't change at all. I think we need to go to ventilate. And we may or may not at that time, but that's our role to advocate there. So all of these indications come down to one thing, and it's really just that the patient can no longer meet their oxygenation or ventilation needs on their own, and we need to step in. So getting started, this is going to be a very, very brief, I want to emphasize that very brief outline of the functionality of this Servo U ventilator, because I know Boise, that's the ventilator you guys are using, a very nice, slick, fancy ventilator. And one of the big things about it is that it's, you know, in the human world, they do all the studies, right? They've got all the money for all the studies. This ventilator was studied specifically in the frame of safety for teams that don't ventilate often, and was found to be one of the safest ventilators, because it basically tells you everything that you need to do, including alarm troubleshooting, which is great. So we're not going to talk about all the functionality, but we are going to talk about some of the key steps in getting a patient set up on a ventilator and some of the key functionalities that you should be aware of as a technician. So when we're talking about initiating ventilation, first thing we're going to do is we're going to plug it in and connect it to oxygen. And we always want to make sure that this is plugged directly into a wall outlet and not a power strip. You're going to locate and open the hatch. This is probably, in my experience, the hardest part, because I always forget where this little hatch is on your ventilator. And then you're going to flip the switch to turn it on. You have to pull that toggle down and move it over. You can't just flip it. You have to actually pull it down. And then it's going to ask you to go through a pre-use check. Now, this has to be done between every patient or with every circuit change. So it's very important. This prompt is going to appear on startup. It's going to ask you if you want to do a pre-use check. Like I said, it has to be run between patients, but also if you're changing the circuit. The illustrations are going to guide you through on this one. So in theory, it's fairly simple. Of course, there are points where nuance is involved, but you will have had that training either from Brooke or your rep to feel comfortable with this pre-use check. And the final test is going to involve your circuit. Now, it's very important to remember that you have to use the exact circuit, not just the exact circuit type, but the exact circuit you intend to ventilate with. And if you're using a humidifier, you want to make sure that that humidifier is turned off and that the chamber is filled with water before you undergo this check. Then you're going to enter a screen that looks like this. The ventilator is in standby mode, and this is where we're going to select our patient size, ventilation type, and ventilation mode. So this is going to be given to you by your criticalist, or your criticalist is going to be doing this themselves. But if you're interested, what this ventilator offers is basically little guides on what each of these parameters mean. You can press and hold those parameters. I would encourage you to do this as you're practicing with your ventilator. I think of this as kind of like CPR, you know, where Recover says you need to practice every 6 months to stay on top of it, because when we need to do CPR, we need to be an expert, but we don't do it that often, right? Same with ventilation. So as you're refamiliarizing yourself with your machine in between patients, it's really nice to remind yourself what all these parameters mean. And it's just helpful little learning that the ventilator offers just as a part of its functionality. When we get our patient on a ventilator and we've initiated ventilation, this is the screen that we're going to be looking at. So there are a couple things that I want to point out here before we go into more specifics. But these down here are going to be the settings that we set. This is going to be different depending on the type of ventilation that you're using, but these are going to be settings that we have actually inputted for the patient. And these are going to be our measured or delivered settings. So this is what it's measuring either from the ventilator itself or from the patient itself. And those are definitely different. And they can be different even if we're looking at something like PEEP, right? Which is a preset thing. We wanted this patient to have a PEEP of 5. You can see here that the PEEP on the patient end is different. 4.9 and 5, that's not that different, but we can definitely see conditions that cause a big divergence there. We'll talk about that a little more later. And then we get the loops and scalers. These are fun, but we're not going to be talking about them. They give us insight into pulmonary dynamics and the type of breath that a patient is receiving. And then we have our menu here. A couple important things on that menu that we're going to talk about in the subsequent slides here. One thing that I want to point out is that we do have to add in our patient's body weight by clicking on this VT-PBW button. So this is tidal volume per patient body weight. This allows our tidal volume display in mils per kg. That can be very helpful because oftentimes when we're ventilating, we're looking at specific targets like between 8 to 12 mils per kg. And it just makes it a lot easier so you don't have to calculate it out. Because of course it's going to give you the raw tidal volume here, but having to calculate that out every time you're looking at tidal volume in mils per kg can be a little bit cumbersome. So this ventilator will do it. We just have to make sure that we're entering the patient body weight. One other thing that I wanted to point out on here is the patient trigger indicator. These are a little set of lungs that will appear on your ventilator every time the patient spontaneously initiates a breath. This is going to be important for monitoring. Of course, there are going to be some times when we want patients to start breathing on their own. So we're looking for this. We want to see this. There are times when we don't want this. Their breaths are crappy or their breaths are fighting the ventilator, and we don't want to see those lungs. It's important to note when the patient's actually triggering a breath. So I just wanted to point that out there. Your criticalist, the doctor who's working on the case with you, is going to be able to give you more guidance as to what this actually means in the context of the case and the mode of ventilation, but that's an important thing to look at there. Another very important function on this Servo U, which is amazing, is the record function. So we can press the camera button, which is this button here in the middle, and we can take a screenshot of the entire screen of the ventilator. We can also press the little recording button here, this thing that says 30 seconds and has that little video recorder, to take 15 seconds of waveform data both before and after pressing the button. So another really important thing to do if you're looking at something, you know, oh my God, this has changed, I don't know what it is, I have to call my criticalist because it's 2:30 in the morning. You can take this record and they'll be able to see exactly what you saw. Great. And then the media button here allows you to access those recordings and screenshots. It's very, very important as a technician. If something weird is happening, you don't have to figure out how to describe it. You don't have to whip out your phone and take a video. You can record it straight from the ventilator. Also important to know how to stop ventilation. So stopping ventilation is pressing the standby button, but you have to press and hold stop ventilation in that standby menu for 2 seconds in order to stop that ventilation fully. And this is when the ventilator is going to enter into standby mode. It's going to remember all your settings. When you come out of standby mode, it's going to go right back to ventilating based on how you had those settings before you went into standby. But this will be important if we're disconnecting the patient for something like chest x-rays or, if we're trying to take them off the ventilator to see how they do. That way you don't have to restart the ventilator. So remember to use that standby button. On that note, we also have a disconnection/suction setting. This is when we might need to disconnect the patient for a very short period of time, 60 seconds or less. So if we're suctioning the endotracheal tube, we obviously have to disconnect the ventilator. We'll talk more about what that looks like later, but this allows us to do that. And then when we reconnect the patient, it gives an increased percentage of oxygen for a short period of time after we reconnect them. And then we have an oxygen boost button. This is your best friend if you're ever worried about a patient. This is typically going to be preset to 100%. You can adjust what it is, but 100% is more or less a standard. And by pushing this button, you're going to give the patient 60 seconds of increased oxygen support. So you will use this prior to disconnecting for any reason, for suction, for chest rads, for weights, whatever it is, or in an emergency. If you're ever concerned about a patient, pop them on 100% oxygen. All right, so more ventilator functionality. We're going to briefly go through alarms. What's really nice about this ventilator is it's going to prioritize alarms. So we have red alarms, like you can see here in this image, that are high priority. yellow that are medium priority, and blue that are low priority. What you're also going to see here is the number of alarms that are currently active. You can click on this alarm and it's going to pull up all of the alarms that are active, but it's going to show the one of the highest priority. Now, when you click on that, all alarm information is displayed along with troubleshooting suggestions, which is super, super awesome. You can silence the alarms. It will only silence them for 2 minutes. So of course, if you forget, it's gonna yell at you again. And your criticalist can adjust alarm limits based on the patient too. So they can set limits that the ventilator will alarm based on what they expect the patient to do. And we're gonna talk about a handful of high priority alarms, what they might indicate, how we can fix them, and what to do in an emergency. But we're not going to go through this in a ton of detail because the ventilator is so smart to help you. But these are going to be the ones that you not necessarily face the most often, but could face in an emergency. And the first one is going to be high airway pressure. But this could mean kinked or blocked tubing, mucus plug in the endotracheal tube or the airways. The patient might be coughing or fighting the ventilator, or you could have a blocked expiratory filter. And what this means is the ventilator's not, it's reaching too high a pressure to deliver a full breath. We absolutely have to correct this because on the patient side, they're not getting a nice big breath. So to troubleshoot this, we want to check the patient circuit, we want to check the expiratory filter, and we want to check their anesthetic depth. If a patient's light and fighting the ventilator, that's just as bad as if they had a kinked or blocked tubing. They're going to be breathing against the ventilator and then the ventilator is not going to be effective. And in an emergency, you can't figure it out or your patient's crashing, switch to an ambu bag with 100% oxygen attached to it and prepare for reintubation. Now, reintubation, because mucus plugs in the endotracheal tube are fairly common, we're going to talk about this in more detail and how we fight that later. But reintubation is going to be much faster than suctioning that tube if it is to the point where it's blocking so badly that we have a high pressure alarm. Apnea is another high priority alarm. Now, just because the patient's on a ventilator doesn't mean the ventilator is automatically delivering breath. It depends on the breath type and the ventilation type that we're delivering to the patient. So there are times when we're expecting the patient to breathe on their own, and the apnea alarm settings allow that alarm to pop up if the patient's not doing that. So possible causes could be that the alarm limit's exceeded. We can set the alarm limit. So we can determine like we're only going to tolerate 10 seconds of apnea, or maybe we'll tolerate 30. Those are going to be preset by your criticalist based on the patient. So if we exceed that limit, the alarm's going to go off. And this really just means that the time between breaths is too long. In order to manage that alarm, we're going to check our patient first, right? Always check our patient. And then we're going to check our ventilator settings. We might need to change the settings on the ventilator to deliver more breaths on its own because the patient's not going to do it on their own. This happens a lot when we're trying to wean. We also might check our alarm settings and make sure that they're set appropriately. Again, changing these is going to be at the discretion of your criticalist, not us, but something to check just in case. You know, if it's set for like 2 seconds, that's a little bit excessive, right? We might change that to 15 or 20. In an emergency, you're going to notice the theme here, switch to an ambu bag with 100% FiO2 and allow the DVM to assess the ventilation mode because that patient may have failed our challenge or our weaning attempt. Patient circuit disconnected is another alarm that you're going to get. This one seems fairly straightforward, right? If we've got a circuit disconnect, the ventilator is going to yell at us and we're going to want to figure out where that disconnection is. Could be problems with the patient circuit, could be excessive leakage. You could have a big leak in your circuit or a big leak from your endotracheal tube. Think a too small tube with a cuff not inflated. Manage this alarm. We're going to check the circuit and all the connections and check the endotracheal tube cuff inflation. And if we can't solve that problem and our patient's in trouble, switch to an ambu bag with 100% oxygen to at least stabilize our patient while we continue to troubleshoot. The final high priority alarm we're going to talk about is expiratory minute volume low. Now, minute volume is the amount of air that's moving through the lungs over the course of a minute, and that's something that we monitor really closely with our ventilated patients. Possible causes of a low minute volume include low spontaneous patient breathing, Our patient just might not be breathing enough to meet the alarm limits that we've previously set. We could have cuff leakage in our endotracheal tube or a smaller leak in the patient circuit. So you're going to get a disconnection error when it's a huge leak. You're going to get a minute volume low error for those smaller leaks. We're going to check our patient. We're going to make sure that our patient's breathing, particularly if they're in a spontaneous ventilator mode. We're going to check endotracheal tube cuff inflation, and we're going to check the circuit and the connections. And again, in an emergency, particularly if our patient's not doing well, we are switching to an ambu bag with 100% FiO2 and breathing for that patient with the ambu bag while we troubleshoot that alarm further. All right, moving on to monitoring parameters. This is going to be, along with nursing care, kind of the bulk of our talk today. So these are obviously going to be some of our highest acuity patients in the hospital. I'm not going to imply that they can't be stable. They certainly can be, but they require a lot of work regardless of their stability, requiring continuous monitoring and a dedicated technician. And they need a dedicated space for reasons that we're going to get into later. So if you're ventilating in the treatment area, which I think is pretty common versus having like a specific room that you might ventilate a patient in, you're going to want to tape off an area, just like you might do for an infectious patient in general population, and you're going to restrict access to that area. So I do want to normalize patient monitoring on these patients a little bit. There's really nothing fundamentally new here if you already know how to monitor critical patients or you know how to monitor anesthesia. This is the same skill set we'd use for those patients as well, with a couple of minor changes and things to consider, but it truly isn't that different. The big difference is the stakes. So these patients are completely dependent on us for ventilation. That's why it's colloquially termed life support. So small changes matter more and big changes happen faster. So instead of thinking this is something totally different and this is terrifying, think this is what I already know, just applied more consistently and more vigilantly. So you're going to be watching trends really closely, but I want you to trust what you're seeing, and I want you to act early on these patients, not just assume that that little change you saw is fine. Like really intervene early, talk to your doctors a lot, especially as you're familiarizing yourself with what these cases entail. So the core monitoring parameters are just what we'd monitor on any critical or anesthetized patient. So we're looking at oxygenation, ventilation, perfusion, and temperature. The ways in which we monitor these patients are going to be a little bit expanded. We are ideally going to be using invasive blood pressures through an arterial catheter. And that same arterial catheter is going to be providing us with arterial blood gases. So in addition to a pulse ox for oxygenation, we're going to be looking at the partial pressure of arterial oxygen. And instead of an end tidal only for ventilation, we're going to be using a partial pressure of arterial CO2. Again, the biggest difference is that these patients are going to be higher acuity. They have continuous dependence on us for support, and there's less of a margin for error. So really, we should be focusing on trends over time to pick up on early recognition of change and then intervening quickly before those changes become scary. Another thing that's going to be different in the way that we monitor these patients is that what we set on the ventilator is not always what the patient's actually receiving. This is very different from like an anesthetic ventilator, right? So the ventilator, as I showed earlier, is going to display set values, so what we've programmed. And then as you can see in the picture here, we have our measured values, so what the patient's actually receiving. And we want to make sure that we are writing down both of them. We are monitoring both of those. If you set a tidal volume and that patient isn't getting that tidal volume, something is wrong. And that difference is often your first clue as to what might be wrong. So for example, if your inspiratory pressures are climbing, but your delivered volume is dropping, that patient might be obstructed in the endotracheal tube or in the airways. If your volume's lower than expected, there might be a leak in your system. Now, the alarm catches a lot of that, but not all of it. So that's why we're looking at the difference between set and delivered values, and we're recording both of those. So don't just write down what the machine is set to, also document what's actually happening. A really common example of this is respiratory rate. We're going to set a respiratory rate, but in a lot of ventilation modes, it's going to allow patients to take breaths. We set a respiratory rate of 10, and they're getting they're measuring a rate of 15. That means the patient's taking 5 spontaneous breaths per minute. It's really good information. We're also going to be writing down respiratory parameters that we might not always write down in the case of anesthetic ventilation or just critical patient monitoring generally. And that can include anything you see on the screen right here. But most of the time, what we're writing down is going to be minute volume, respiratory rate, positive end expiratory pressure, or PEEP, and then peak inspiratory pressure, or on the servo U, they call it P-peak. One of those annoying things. The ventilators are going to have different shorthands for the same concept. So just familiarize yourself with your ventilator. It is definitely beyond this talk to go through what all of those mean, but we are going to be writing those down. The other thing that I should note that we'll probably be writing down that I don't have written here is inspiratory to expiratory ratio, or I to E, because that's one of those things that we can adjust and often do adjust based on the patient's disease process or status. So again, I'm not going to be talking about every parameter that we're going to monitor because it is going to be fairly consistent with critical patient monitoring or anesthesia monitoring. But capnography is one of those parameters that's really important to ventilation specifically. So while I'm assuming that you already know what normal values are and what these parameters mean, I am going to focus on a few key insights that are specific to these patients. And that's because I don't want to keep you all here for 3 or 4 hours. So I'm sure if you want more information on all of the other parameters, your CES can hook you up with some great resources. But with capnography, what becomes incredibly important in ventilated patients is waveform capnography. And that is different than just our end tidal CO2. The end tidal gives you a number, which is really helpful, but it doesn't tell you the whole story. Instead, the waveform is going to show you how that number is being generated. And it's often the first place we're going to see some common problems associated with ventilator patients. Don't just look at the number. We're always going to be looking at the shape. And this is the shape of a normal capnograph. So this is ideally what we'd like to see. So this is CO2 levels here, and this is time over here. So in inspiration, there should be 0 CO2. So we have that respiratory baseline, which should be down to 0. As soon as expiration starts, we see this expiratory upstroke as CO2 levels build in the air that's going through that capnograph. And then we get the alveolar plateau. This is where we are at the point of exhalation, where all of the air from the distal lungs are moving through the capnograph. So we have a higher concentration of CO2 here. And at the very end of expiration, where end tidal is measured, that's considered to be the most representative of venous or arterial CO2 levels. So that's why we really look at end tidal. But of course, we're talking about waveform capnography. So the next waveform that we look at is the inspiratory downstroke. And this is when the ventilator is delivering a breath. CO2 levels should drop very rapidly in a normal breath, and we return to our respiratory baseline, which should ideally be 0. So when our waveforms go wrong, it can indicate specific problems. Now, there are a number of things that we could look at with our capnograph in ventilated patients, but I am only going to talk about one today because this is the one that as a technician, you should have seared into the back of your retinas to be able to recognize, and that is an airway obstruction, because this is very common in ventilated patients. We can do the best airway care, and we're still going to potentially face airway obstructions. And this is a life-threatening rapid emergency if it reaches a complete obstruction. But we can correct this quickly and avoid those big scary moments if we know what waveforms we're looking at. Basically, what we're looking at here is you can see that this is going to be the waveform of a normal capnograph. We've got that nice plateau here, really sharp drops or rises on inhalation and exhalation side of the waveform. Now, when there's an airway obstruction, either in the endotracheal tube or in the airways themselves, it can also happen. What we're going to see is that exhalation on that patient is meeting resistance, right? Because they're trying to breathe through a smaller and smaller area as that obstruction worsens, which means the airflow is going to be stilted, and we're going to get this sort of shallower line on our capnograph waveform. And this is called a shark fin waveform. It's a nice way to remember it, that nice steep increase, plateau, and steep decrease, we get this shark fin. And it's usually on the exhalation side The ventilator's breath is strong enough to counteract that on the inhalation side until the obstruction becomes severe. You can see that as the obstruction worsens, this gets flatter and flatter and flatter until we just have a big 0 for a complete obstruction. Now in real time, this is what that looks like. So this is one that I caught on one of my patients. It wasn't bad enough that I couldn't snag a picture first. That this is an indication that we need to reintubate. You can suction this tube, but as I mentioned, intubation is pretty quick. Yes, it takes 2 people, but so does suctioning, really. It's better to just get that tube out if we've got an obstruction that's bad enough to affect the capnograph waveform. But if you start seeing waveforms like this, start getting ready for reintubation and go grab your doctor. All right, moving on. We talked a little bit about the blood gas parameters that we're going to look at, but one thing that I really wanted to mention was that reporting of blood gas values is going to be really, really important. And the way in which we report them and the information that we provide in EasyVet as we're running our blood gases is going to play a big role in how we interpret these. So we're not going to go through art line placement or ABG interpretation, but we are going to talk about the things that we need to understand to report them, but also to know that our sample is arterial. Now, if we have an art line in, we're going to know that that sample is arterial. But if we're taking it off the needle, that can be deceptively difficult. Now, in a healthy patient, we're going to expect our SO2 to be 99 or 100. If it's 99 or 100, we're good to go. Now, in a ventilated patient that might have respiratory disease, this could very easily be like 87. And we might look at that and think that it's venous versus arterial, but it could truly be like 87 because our patients are having difficulty oxygenating. So how do we know that our sample is arterial if we're taking it off the needle in cases like that? Well, we can confirm with our pulse ox. That's a really nice, easy one. If the SO2 matches our pulse ox, these are measuring the same thing, then we know that our sample is arterial. The other thing that we can do is pull a venous sample and compare if needed. Our venous sample should have a significantly lower SO2 than our arterial sample. There's no standard for how much lower because there are just a million unmeasurable variables like metabolic rate that go into that. But if it's significantly lower, we can probably count on that initial sample being arterial. That's the first thing. We need to make sure that we got the right sample. Now, when we are reporting results, this is where the additional information that we might not report when we're running these like under anesthesia become really, really important. So first and foremost, we need to mark down that the sample is arterial, fairly obviously. That has to be reported somewhere. We also need to make sure that the fraction of inspired oxygen is written down as well. We'll do calculations on the back end. You can see that PF ratio here, where we need that fraction of inspired oxygen. So when we're doing this for a patient under anesthesia, for example, we always know it's going to be 100% because they're on an anesthetic ventilator or an anesthetic circuit. If we're doing it for a patient on room air, we always know that it's going to be 21%, right? But on a ventilator, it could be anything that we set it to. So we need to make sure that we are, with every sample, writing that down into the record with that test result. Because if we go back into the record, that's information that we're going to want to have from that point in time as well. The other thing that we also always have to report with these results is our end tidal CO2 at the time that sample was drawn. And this is because we're going to use that end tidal CO2 and the arterial CO2 to look for certain things, particularly dead space. And that's going to be important to note with every sample that we include. Temperature corrected values are also important. So I'm less familiar with how the epochs report those temperature corrected values, more familiar with the ISTAT. The ISTAT would report those temperature corrected values, but the information that we entered was not necessarily the temperature corrected values. So I always make sure that my temperature corrected values are written down here. You can see that they can diverge pretty significantly from what your non-temperature corrected values are. And so again, in these super high acuity cases where little things really matter, very, very important to note. All right, I'm going to pause and just take a look at the chat and make sure that I'm not running by a bunch of questions. Oh, Victoria. So do patients need to be reintubated at certain intervals? Yes, they do. And in this next section, we are going to be talking about that first. That's a great segue. Thank you. So we are going to be moving into what I think is the most important thing about these ventilated patients, which is nursing care, which means your role as a technician is pivotal. So when these patients are right on the edge, I truly believe and have absolutely seen that nursing care can make or break the case. So at this point, it's not about one big intervention. It's about all the small things done well and done consistently. Starting with airway care. Obviously a pretty big one, since these patients are going to be intubated potentially for a very long time. Here is Cosmo again, kind of in his twilight, looking at me, being all cute. So why does airway management matter so much? Well, a big one is that intubated patients cannot cough or clear secretions. So this is one of the most important concepts in this entire lecture. Second, we intubate a patient, we remove their ability to protect their airway. And if they can't cough and they can't clear secretions, everything we normally rely on the body to do is now our responsibility. A lot of ventilated patient crashes are airway related. So this is your first thought when something goes wrong. More generally, intubated patients and ventilated patients are at risk of airway obstruction, hypoxemia, and infection. Ventilator-acquired pneumonia is very common. If they didn't have pneumonia when they went on the ventilator, it's more than likely that they're going to catch it when they are on the ventilator. So we need to make sure that everything we're doing is remembering those complications that can cause, because we don't want our patients to suddenly crash. We can catch most of these before we get to that. And a big thing that we can do is maintain that endotracheal tube appropriately. So when we're talking about endotracheal tube maintenance, we're talking about both function, making sure that endotracheal tube works, and tissue health. If we leave the tube in one spot for too long, we can cause a pressure injury. So it's really important to monitor that cuff pressure using little pressure manometer guys can be super helpful. Daily replacement of the endotracheal tube in the hospital. Oh, is somebody chatting? Did I miss a question?
Sorry, yeah, I didn't want to interrupt you. Victoria asked about re-intubating patients. Do you do it at certain intervals when they're being ventilated?
We are talking about that now, Brooke. Thank you. So we want to replace the endotracheal tube at least every 24 hours. Oftentimes, a patient might, I'm going to mute somebody. There we go. Oftentimes, we might need to replace it more frequently than that, but at minimum, every 24 hours. And for our longer-term ventilated patients, it's common practice to culture that endotracheal tube weekly. Again, ventilator-acquired pneumonia is fairly common, and we want to keep an eye on those microbes that might be brewing. So when you do take that endotracheal tube out, don't just toss it right away. You want to ask about a culture on that. I'll often proactively grab a culture swab and just ask if we need to submit it or not. The common complications associated with the endotracheal tube include mucus plugging. This is a big one. Again, we talked about this with waveform capnography. This can happen really quickly and become life-threatening, but there are signs most of the time before it gets to this point. So if you are having concerns with your patient, you always want to rule out an obstruction first. Kinking or displacement of the endotracheal tube is common, so we always want to check and make sure that it is sitting in a natural position and that it's not coming in or out unnecessarily. Cuff leaks are common, and biofilm formation. So biofilm is like if a bacterial infection is like a nomad, let's say, just a human or a couple of humans wandering around in the world, a biofilm is like a fortress with a city behind it. So biofilms are groups of bacteria that kind of come together and work together. So it's typically multiple bacteria, but they have defenses that are greater than the sum of their parts. So we really watch out for biofilms. It's why we're replacing every 24 hours, but it's also why we're culturing fairly frequently so that we know if there is some introduction of bacteria that wasn't previously there from the formation of a biofilm. So keys that might cue you into needing to do endotracheal tube maintenance more frequently could be increased airway pressures, decreased tidal volume, or those waveform changes on the Kaplan graph that we talked about before. The next bit of airway maintenance that we're going to have to do, this is typically done by the doctor, and does need to be sterile, is suctioning the airway. This is not just suctioning the endotracheal tube, but we suction the airway as well. Again, these patients can't cough, and we can get buildup of those secretions outside of the endotracheal tube, and we can have bronchi obstructed from a mucus plug. So we're going to suction typically at a minimum of every 4 hours, but more as needed. And this does require disconnection from the anesthetic circuit. So it requires coordination with the doctor that's going to perform the suction. And we are going to use that oxygen boost button to give that extra oxygen for a full minute prior to disconnecting. Oftentimes we're going to suction twice, but in between suctions, we're going to reconnect, give 100% oxygen, and then disconnect and suction again. Complications during suctioning are common, could include hypoxemia, especially for our sicker guys. So that's why we're giving that oxygen boost. And you as a technician, while your doctor's focusing on suctioning, you're watching your patient. And if there is trouble with your patient, you are telling that doctor to get out of there and you're reconnecting them as fast as possible. We can cause airway trauma if we're not careful with our suction. Now, another thing that we should be looking at as a technician is a vasovagal reflex. Very common during suctioning. I always like to have atropine pre-drawn up for this reason. If that patient's heart rate starts dropping during suctioning, you let your doctor know and they should be getting out of there. If it doesn't stop dropping, you're going to be giving that atropine. And then, of course, because we're introducing something into the airways, not only the proximal third of the trachea is considered non-sterile, the distal 2/3 is considered sterile. So we could introduce infection if we're not doing this carefully and sterilely. And then we have circuit and humidification maintenance. So we should really be changing the entire ventilator circuit every 24 hours. Yes, this will require another pre-use check. Of course, we're always changing between patients, and then we are replacing it if it becomes soiled. Again, ventilator-acquired pneumonia is something we'd really like to avoid if we can help it. But then we also have to manage our humidifier. So intubation is going to remove natural humidification through the nose. So when we bypass the upper airway, we lose that humidification, which is going to make our secretions thicker, stickier, and can cause inflammation in the airways. So humidification is directly tied to airway health and airway patency. So we have a couple options for humidification. You might be using a humidifier, which is typically going to be cut in line to the tube or the circuit itself, or you could use an HME filter, which is a heat moisture exchange filter, kind of like an artificial nose. I really like those guys. I find them less finicky than a humidifier, although the humidifiers are more effective. So it's a trade-off there. But we need to be changing those HME filters every time we change the circuit. And we need to be checking that humidifier to make sure that there's enough water in the chamber to continue to humidify that patient when we are checking our circuit as well. So moving on to oral care. So kind of up from the airways into the mouth. Oral care is another hugely important aspect of our nursing care. And I have 3 pictures of what can happen in the mouth as a result of ventilation. The first is necrosis of the tip of the tongue. Now this is actually this patient coded and was on pretty high doses of both norepi and vasopressin, if I'm remembering correctly. So massive amounts of pressors. We saw the tip of the tongue necrosis as a result of that because those pressors, they constrict capillary beds and then the tongue wasn't getting any blood flow. That was necessary to save this patient's life. But unfortunately, it did require a lot of maintenance. This guy did survive. He had a little snake tongue afterwards, but he did survive. But we needed to make sure that this was not going to be a secondary source of infection for that patient. We can also see the development of ranulas, these little swollen blister-like things under the tongue. These can get pretty massive. They can be really uncomfortable. And in a frenzy like this, they can be enough that that airway is just closed a little bit too much so that when we extubate, they have trouble breathing. So we want to prevent those as well. And then this is a tongue whose mucosa got ripped off because it wasn't being kept moist enough. Again, oral care is difficult. It requires a lot of maintenance. Sounds like it shouldn't be, but it is. And this is through no fault of the nurse. I think they were probably more focused on saving a life at that point, but it is something we had to manage post-op or after the fact. So when we're talking about oral care, we can reduce the risk of ventilator-acquired pneumonia with really good oral care because we're removing bacteria and debris from the mouth. But we're also going to be able to maintain mucosal integrity and comfort. So when we first think of oral care, we're thinking about keeping that mouth moist. We have a handful of options. We could just use tap water. I like using a mixture of 1-to-1 glycerin and water because it keeps the mouth moist longer than just water alone. And then chlorhexidine can be helpful from an antimicrobial standpoint. If you are going to use chlorhexidine, it's important to remember that it can be irritating or even toxic to tissues if we just let it sit there in the mouth. If we are going to use chlorhexidine, we should follow it with a rinse of either glycerin and water or just water. For technique, I prefer to use curved hemostats with a cotton ball that's been soaked in the solution that I'm using. And then we are scrubbing every bit of that mouth. So the teeth, like the buccal and lingual side, the gums, the tongue, the palate, all of it. Every time that cotton ball starts looking a little gross, we swap it out for another one and keep scrubbing until we get a clean cotton ball everywhere. Now, before we start, we want to make sure that the endotracheal tube cuff is inflated so that we don't have a bunch of fluid going down into the airway. And then after we're done, we're going to be suctioning all of that fluid out with a Yankauer. That stuff is especially important if you're using chlorhexidine, but we don't want all of that water just sitting in there. Then you can follow with another rinse and suction again. One thing that I also include in my oral care is just a tongue massage. It can prevent the development of those ranulas or help reduce those ranulas if they do develop. So I will massage the tongue, move it around, inspect everything as well. Key point here, as I mentioned, make sure the endotracheal tube is inflated, but also make sure that all the gauze and cotton swabs are removed after cleaning. We're always just going to assume that we have to do an emergency intubation at any moment in these patients. And we don't want to have to go fishing around for a piece of gauze that's in the back of the airway before we are extubating. And we definitely don't want to be shoving a piece of gauze down into the airway if we missed it. Next is recumbency care. This is what I think is probably one of the most important and most overlooked parts of managing ventilated patients. They can't move themselves. So every complication from immobility becomes our responsibility. If we don't reposition these patients, they can develop pressure sores, sometimes very, very quickly. You can also notice worsening lung function due to atelectasis, especially if they're in one position for too long. And then on top of that, we have risk for nerve damage and significant muscle loss. So in general, we're going to reposition about every 4 hours, but it's not a rigid rule. You can always adjust based on patient stability. So some patients might tolerate more frequent turns, others might need a slower approach. Some might need to be in a particular recumbency as a result of their pulmonary dynamics. So we need to make sure that we're talking to our clinicians about that as well. When we are doing recumbency care, typically we're repositioning again every 4 hours. We're alternating sides. So left, right, sternal. Now the thorax should remain sternal in most cases. This is not always true, as I alluded to. But when we're talking about doing recumbency care, but keeping the thorax sternal, it's rotating the hips. So it's hips left, hips sternal, hips right. I'll also alternate between sort of like frog legs forward and legs backwards. And then we want to make sure that we're also giving those shoulders some relief. If we have a patient leaning on one shoulder or leaning on both shoulders or leaning on both elbows for too long, that can be irritating as well. So really the approach is going to be somewhat patient specific, but we always want to be looking at patient alignment, making sure that those areas where pressure can develop are being alleviated at some regular interval. Now, when we are changing recumbency, it's important to watch how the patient responds. So we might see changes in blood pressure, oxygen saturation, or ventilator pressures, and that's important feedback. So if something changes significantly, stop and reassess, hit that record button on the servo U, and make a note of what you were doing as you were changing that patient, because that could be very important information for your critics list. So this is not just a task to check off. It's good recumbency care should really be proactive. And it's one of those areas where excellent nursing care really shows. Because of course we're treating these patients like they're going to come off the ventilator, right? And if they come off the ventilator and they can't walk for 2 weeks, that's a problem. We want to make sure that these patients come off the ventilator. And yeah, it's going to be a while. It's going to involve some rehab when they're off the ventilator, but good recumbency care while they're on the ventilator can really make that a lot easier for the patient. Which leads me to passive range of motion and massage. This is sort of the next sort of rehab care that we're going to be providing for these patients. Now, PROM maintains joint mobility and prevents stiffness, but it also supports circulation. It is not going to build muscle. These patients are going to have muscle atrophy, and there's not much we can do about that. Now, in Boise, I know you have a rehab department. Great to engage them on some of these longer-term vent cases, because they might be able to help prevent some of that muscle atrophy with their TENS stimulator, for example. So this is one of those interventions that doesn't look dramatic, but it definitely impacts the recovery phase of these patients. So with passive range of motion, we are moving all joints through full natural range. This includes finger joints and toe joints, literally every joint. We're going to perform this every 4 hours, and we're going to focus on flexion and extension of those joints using gentle, controlled movements. We're not going to force movement, so we're going to stop if there's resistance, and we're going to stop if we note pain. Now, these patients are kind of in a twilight sedation, so they should still have a pain response. If you see that heart rate go up, maybe back off on your PROM a little bit for whatever joint that is. Now, massage therapy is also important, and this is something that I do yes, every 4 hours with my PROM, but just passively. If I am not doing other things on that patient, I will just automatically start massaging them. I have seen the worst of the worst when they get to terrible, terrible peripheral limb edema or catheter site edema. And it's so hard to combat when it develops, and it is going to develop. I mean, I'm sorry, like it's just going to happen. But if we can be proactive with our PROM, then we can hopefully avoid the worst of it. Now, I realize we are at time. Brooke has kindly given me permission to go over, but I understand that those of you joining might not have that same permission. So if you hop off, I won't be offended. This will be recorded for you to see the rest of it. Yeah, I'm going to keep going. Michaela, I see you unmuted. Do you have a question? I'm going to take that as a no. All right. So safely moving or weighing the patient. I do want to chat about this because this feels like it should be easy. It's really not. But weights are incredibly important because they're going to be very helpful in determining fluid balance in these guys. But like I said, they're deceivingly difficult and can oftentimes take more than one person. So you have to be really organized, obviously, when moving or weighing a patient. Obviously when moving a patient, but also when weighing a patient. So this involves line organization, which we'll talk about in a couple slides, but also the way in which you're disconnecting them from their monitoring, what monitoring you leave on. Coordinate with your doctor. Definitely coordinate with your doctor when you're doing this, especially as you're new to ventilation. One tip for weighing that I really like is that there are a couple manufacturers of little like portable baby scales that go up to 120 kgs. So for smaller patients, I will bring them right to the patient. I will remove all the bedding from my patient, and I can keep them hooked up to the ventilator. I can keep them hooked up to the monitoring. I will weigh myself, and then I'll weigh myself holding the patient. And that way, that's probably the safest way, but that's obviously not every way that we can weigh a patient. We have a massive patient, for example, I can't do that. So then we are going to have to disconnect. And this is definitely a controlled event. So I organize all of my lines first and make sure that they are all very clearly labeled and they have a safe spot where I can really rapidly reconnect those lines when I bring the patient back. And the same goes for monitoring equipment. I make sure that everything's organized, and I'm not just like disconnecting that ECG and throwing it, I'm disconnecting that ECG and clipping it in a really obvious spot. I make sure that I have an ambu bag with mobile oxygen tanks if I have to move the patient. And then the final thing that we're doing after we disconnect everything else is disconnecting them from the ventilator. That should be the very last thing. I will always have a mobile pulse ox with me so that as I'm moving the patient, I have some way of continuing to monitor them, but I'm going to be breathing for them with an ambu bag. An EMA capnograph can be really helpful here too. But this applies to anything. If we're moving them for weights, for x-rays, if we're transporting them for a procedure, we have to be super duper organized, not just in the way that we disconnect them, but also in the way that we set ourselves up for reconnection, making sure we know where everything is. And we don't have to go through a bunch of untangling to reconnect the patient. So this does involve planning and think through the steps before you start to do it so that it's smooth and safe. And I do want to stress the importance of weights here. They are inconvenient. They feel very easy to skip, but it's really, really important that you don't because they give us a ton of information on these supercritical patients. Next is management of tubes and lines. I, again, am not going to go through all of the specifics. The way in which you perform catheter care, for example, could be different between hospitals. There are a lot of right ways to do things. I'm not going to go to that granular of a detail, but I am going to talk about the importance here and give some just general principles. Every tube and catheter needs to be labeled very clearly, secured, clean, and checked regularly. You should be looking at these every shift, if not more often. Again, these patients are immunocompromised. They're at really high risk of infection. A bad catheter could do it. And these guys are already going to be inflammatory just by nature of being on the ventilator. So we don't want to introduce any more infection or inflammation if we can help it. Definitely every shift, but we are going to be fully breaking down every tube and line and inspecting them and cleaning them every 24 hours, more if needed. We're checking for function. So we're flushing those IV catheters. We're making sure urinary catheters are flowing. Don't flush them unless you're using absolutely sterile techniques, sterile gloves, sterile everything. You don't want to introduce infection here. And then we want to minimize unnecessary manipulation, particularly with those arterial lines. Arteriospasm can be really, really annoying. And the less we manipulate those catheters, the less we get back. So follow your hospital protocols for the details, but just use good common sense general principles for every single line of the patient and making sure that you're checking them every single shift or as needed, not just when it's scheduled on the treatment sheet. Okay, we are moving into our final section. So I appreciate those of you who have stayed with me here. This is another really big one and another sort of deceivingly important one. We need to be really clean and really organized with these guys. There is a lot going on, and I don't know, I feel like it's kind of old-timey, and I hate saying it. I don't know why, but I do hate saying it. But the cluttered desk, cluttered mind thing, I believe that when it comes to these patients. And I'm a person that tends to be okay in clutter, not in these guys. Super organized, super set up. Because if I need something, I'm going to need it fast and I need to know exactly where it is. And I don't want to be running away from my patient to grab stuff a lot. I'm leaving my patient's side, and I don't like that. But also, I'm moving out of that safe, controlled ventilator area around a dirty ER or a dirty ICU, and then bringing all of that back to my patient. So we really want to minimize that as well. First, let's talk about supply setup. Now, we need to make sure that if something happens, we don't have to go looking for anything, and that everything that we need to take care of the patient is within arm's reach. Now, we will have setups for airway and emergency equipment, and then we're going to have setups for all of the other things we're doing. But airway and emergency equipment is going to be the most important. So in that crazy initial shift when a patient goes on the ventilator and it's like the wheels have come off the bus and a tornado's gone through the hospital and everything's everywhere, this is the exception to that. We have to have our airway and emergency equipment right there and very organized. That includes spare endotracheal tubes in multiple sizes. Yes, the size that you initially intubated with, but other sizes as well. and everything that we need for intubation. So laryngoscope, tie for securing the tube, and sterile gloves. These guys are intubated sterilely. So those endotracheal tubes have to be sterile, and we have to have sterile gloves in the size of the doctor who's going to be intubating as well. On top of that, we need to have an induction drug. Like, yes, these patients aren't on anesthetic CRIs, but most of the time they're not fully anesthetized. They're kept in sort of a twilight. They really, in most cases, don't need to be fully anesthetized. There are exceptions to that, absolutely. But we want to make sure that we have an induction drug, whether it's etomidate or propofol or Alfax, whatever we're using. And we want to know the dose of that. So if we have to change that endotracheal tube really quickly because of a mucus plug, for example, we're not scrambling around trying to find our propofol. We're not trying to intubate a dog that's like biting us. We want to make sure that we're all set up to go. We should have doses of emergency drugs readily available. Yes, they're in SmartFlow. In this case, I also like to have the main ones written down somewhere or on a sheet somewhere, so I don't have to grab a tablet and go into the emergency drug sheet if I need it. I will often have a dose of atropine pre-drawn, again, because of how common it is that they will vagal during suctioning. So I'll just have that atropine pre-drawn up. And then we need an ambu bag and a mobile oxygen source. Again, if we talked about with those high priority alarms, if anything is wrong with the ventilator and can't immediately troubleshoot it and your patient's in trouble, ambu bag and 100% oxygen is attached to that ambu bag is going to be the solution. We're going to switch them to that ambu bag while somebody else figures out the ventilator, because the patient's always going to come first. And then we also want to have suction as a part of this setup with suction tubing, suction canister, all the things. We also want multiple different types of suction tips. So a Yankauer, and then those sterile suction catheters. Other supplies that we might have set up that are secondary to the airway and emergency equipment are going to be anything you're using for airway care. So your little cuff manometer, you're going to have line and catheter supplies, oral care supplies, monitoring and procedure supplies, extra batteries for your pulse ox, cartridges for your iStat, I know you're using epox, most of you now, so that wouldn't really apply as much to run a little bit differently, but everything that you need there. And then, of course, cleaning supplies. You want to keep everything visible, organized, and labeled. You want to standardize this setup across shifts so everybody knows where everything is at all times, and then restocking every shift. Restocking is a part of patient care, especially in these cases, to make sure the next person's set up for success. Let's see. Is there a concern for using tie gauze? And should we be using something that can't house bacteria? I have not had issues with tie gauze, again, because we're changing it every 4 hours. Every time I do endotracheal tube care, I change that tie gauze. But it's just a function of what I used previously. There are better options. Now, I think those like orange little shoestringy things have a trade-off. They're not going to harbor bacteria, but if they're tied tightly, and endotracheal tubes should not be like cinched in. These patients shouldn't be moving a lot. In fact, most of the time, if I'm directly with a patient, they're very, very loosely tied. But those little orange guys, I've seen them cut into the commissures and cause like little like Joker smiles or like Glasgow smiles on patients, which is no good. So you can buffer that with a piece of glycerin-soaked gauze, which can help. But as long as you are regularly changing those ties as you should be, I have never seen an issue with tie gauze causing an infection. But again, they were changed every 4 hours. There's, I think, a trade-off to everything you're going to use. So good question. But yeah, I think like umbilical tape has that same potential ability to really like cut into the sides of the mouth. So you just need to be careful about what you use and think about the pros and cons and treat the patient appropriately. So moving on to line management. These patients often have multiple lines running at once. And so this is an area where things could go pretty wrong pretty quickly if we aren't organized. So we, with good line management, should hopefully prevent medication errors, make sure that drugs are being delivered accurately, and reduce the risk of line dislodgement, occlusion, and contamination. But also when we're moving these patients, we want to know where those lines are when we're disconnecting so we can reconnect them quickly. Like we should be really organized. And in a lot of cases, these patients could have like 9+ CRIs or 9+ lines. So we want to make sure that all lines are labeled clearly and in multiple places. I like to label them at any place that they could be disconnected, like at an extension set and at the port. So that's a lot of labeling on all these lines. But when you've got 9+ lines going to a patient, you want to make sure it's very clear where those lines are going. And before I connect or adjust any line, I'm going to trace that fully so I know exactly where it's going. We want to make sure that these lines stay untangled, they're all secured, and that they're visible at all times. I don't like it when my lines are running under blankets or like under the table. I want to see all of them. And then I will separate lines by purpose. This could be unique to what your ICU or critical care team prefers to do. But what I like to do is I'd grab a handful of different colored vet wrap, and I would have crystalloid fluids. Sometimes I was running multiple types. I would have blood products. I would have anesthetic CRIs. I would have pressors. And then I would have sort of like extra CRIs like Reglan or KCL. And I'd vet wrap in places in a color coded way. So I had my anesthetic bundle, all individually labeled, but all bundled as anesthetic. I have my pressor bundle, etc. I find that to be the most helpful, but you can do your own thing. Another thing to touch on that's really important is CRI porting. So incompatible drugs should run as directly as possible into the patient. So the closest port to the catheter hub. And vasopressors should have dedicated lines. Sedatives and anesthetics should have dedicated lines, and then your fluids should have dedicated lines. And this is to avoid accidental boluses of things like vasopressors or sedatives when we give a crystalloid bolus, for example. Now, for those drugs that have to go directly into a catheter, midazolam is a good example of one that really doesn't play well with others and can crystallize in the line over time. And then vasopressors being another one because the rate at which they're administered has to be so carefully titrated and they really can't be bolus. I like to use the blunt tip like catheter port and put it directly into the T port or directly into the central line so that there's no potential for admixing with other drugs. And then I will have a dedicated extension set that's for administering things like those little bolus drugs like Cerenia or pantoprazole or ondansetron or any other drugs that you might be giving as a short bolus, with another line for those longer bolus drugs like enrofloxacin or Unison. So these are all the things that I like to set up. I think you and your teams will have your own unique preferences, and that's okay. There are a lot of right ways to do this, but we need to be really conscious on how we are porting in our lines and not just popping things into the closest port on our crystalloid line. Because as that crystalloid rate changes, or as we decide to bolus them, that's going to change the rate at which all of those other drugs are administered. And again, those little things can make a really big difference in this patient. But finally, cleaning. Talked a lot about ventilator-acquired pneumonia here. These patients are immunocompromised and at high risk of infection, whether that's pneumonia or other types of infections. So at minimum, everything gets cleaned every 24 hours. This is not just the patient space, but also the ventilator itself, especially the areas you're touching a lot. Suction canisters and tubing should be changed daily, along with anything that we're repeatedly using for patient care, like the hemostats that we might be using for oral care, for example. Condensation in the circuit is also something to pay attention to. So we want to make sure that we're draining that condensation in the circuit. So it's not just this like nice moist bacteria pool. We don't want to be flicking it at the patient. We don't want to be flicking it across the ICU. Making sure that we're draining that condensation into a container before we reconnect them is helpful. And then every 48 hours, we want to make sure that we're changing the ventilator circuit, but also the fluid lines, including any CRI lines. This will reduce infection risk. Any sort of mixture of those drugs where precipitates might be starting to develop in those lines can be completely eliminated by doing this. And then we should also be changing filters. So our ventilator filters, but also our HME if we're using one. And then of course, if anything looks dirty or isn't working right, change it immediately, don't wait. Good cleaning practices are a pretty easy way to prevent major complications. I think in these cases, if something goes wrong, we don't always get a cause of it. Usually it's the culmination of a bunch of different causes. And I think if we're thoughtful about all of the things that we talked about today, we really do minimize that. So if you take nothing else from today, I really hope I was able to relay that all these patients are complex. The priorities are kind of simple, even if they're not easy. So we want to make sure that the airway is protected, watching our trends and alerting our doctor early when something changes. So a lot of what determines the outcome in these patients isn't one big intervention. It's all of the small things that are done consistently and done well. The organization, attention to detail, and anticipating problems before they happen is how we're going to do that. So even if you don't see these cases often, it really doesn't mean that you can't manage them well. You just need to be prepared, and you need to make sure that understand what you're getting into, and that involves potentially some regular upkeep of this knowledge and these skills. It is not about being perfect. It's about being thoughtful and about being ready. And so while these cases are hard, they really truly are some of the most rewarding ones we get. This is Cosmo again, getting some outside rehab in the sun. And it was like a day after he came off the ventilator. Like he's just a little goober boy. And when you get these types of patients, you really do feel that it's worth it. And it's just absolutely so rewarding. So I wanted to thank you all for joining me today. This is another patient's spit bubble. He couldn't really control his drool for 3 or 4 days after the ventilator. But are there any questions that you guys have that I can answer? And Victoria, did I answer your questions thoroughly enough? Slash, do you want to argue with me? Because I'm open to that too.
Yes, you answered my questions. Stuff has changed since the last time I had a vent patient, so thank you.
Sure. Well, for those who might not want to type in the chat or unmute, you can always ask me questions over Teams. I'm very happy to answer them. I will drop a copy of the PowerPoint, Audra, into the chat here so everybody who attended has it. And then the recording will also be available on this chat as well if you wanted to go back and refer to it. But thank you so much for joining. I hope this was helpful. And like I said, you can't get me to shut up about ventilation. So if you want to talk to me about it or ask me a question, even if it's a couple months from now, very happy to answer it. Don't feel shy at all. I'd love the excuse.
All right. Thank you so much, Emily. Appreciate it. Hold on, my people here have a question. Here's yours.
I was wondering for the patient trigger alert on when they've taken a breath, does it keep a history of that and is it time stamped?
No. The way in which it's going to track that over time is with the respiratory rate. You'll have your preset respiratory rate and your actual measured respiratory rate. And when those are different, your patient's triggering a breath. But it's not going to like track it over time or timestamp it. If they're doing something funny and it's triggering a breath, but you're not quite sure what's going on, you can always hit that record button in order to capture it. But really, it's going to be the difference between the measured respiratory rate and the preset respiratory rate. It's going to be sort of your marker of that.
Thank you.
Thank you.
Sure. I'll hang on for a couple more minutes. I'll get the PowerPoint dropped in the chat as well for you all. But if there are any other questions, I'll hang on for a little bit longer. Thank you for organizing this, Brooke.
Yes, thank you so much, Emily. Appreciate you.
Thank you, Brooke. You're the best.
You're welcome.